Bien, eh bien, écoutez, bienvenue à tous ceux qui nous ont rejoints dans cette salle pour ce symposium très international concernant la buprénorphine à longue durée d'action, où vous allez pouvoir bénéficier d'une expérience internationale, donc de différents produits où le médicament aujourd'hui est présent, utilisé. Et donc, ça sera intéressant de croiser les regards, puisque nous aurons regards américains, australiens, français. Donc, ça va être une grande richesse, effectivement, et anglais, bien entendu, puisque nous aurons John Marsden aussi, qui nous rejoindra en présentiel, mais connecté uniquement, donc, lorsqu'on prendra la discussion, les questions. Donc, c'est pour ça qu'on va peut-être regrouper les questions à la fin, ce qui sera plus simple, effectivement, pour John Marsden donc, de se connecter. Sa présentation sera faite sous forme de vidéo. Et donc un sujet aujourd'hui d'actualité extrêmement important. Et je vais donc laisser la parole à MAREMMANI, justement, pour la présentation de Roger Weiss et Adrian DUNLOP. Merci.
Thank you, Maurice. And I want to say something about the long-acting treatments for opioid use disorder. Why? Because 30 years ago, we started this strain adventure to treat opioid addiction. And the introduction of long-acting is really different from the introduction of long-acting psychiatry. And we must pay attention to this issue, because in psychiatry we started to use long-acting depot when there was no compliance from patients, when we don't have any other possibility to treat this kind of population. We used the depot formulation. In my opinion, for substance abuse is completely different, and especially for opioid addiction, because the treatment is like for psychiatric patients, long-term, for life, probably. And it's important not to stop treatment. And it's important to facilitate, to remain in treatment, especially for responder people, because it's crazy to have people rebuilt socially and personally, and then to stop treatment, because if we stop treatment, 90% of the population can relapse the first year of treatment. So recovered people can restart the process. Anyway, the illness is chronic brain relapsing disease. So the relapsing is the most important part, and we must interrupt the relapsing. Long-acting opioid, in my opinion, is very, very good for that, because we must prolong the treatment of our patients. But why? We have the reference point for deciding when to stop and when to continue. And this is the challenge we have at the present. I am proud to introduce Roger Weiss from Boston, because Roger Weiss is very famous, doesn't need any presentation. And the title of the presentation, Ethical and Other Challenges in Studying Discontinuation of Opioid Substitution Treatment. Thank you very much.
Thank you so much. And thank you to the organizers of the conference for inviting me to this great conference in this lovely place. In today's talk, I'm going to be reviewing what is known and what is not known about discontinuation of buprenorphine treatment of opioid use disorder, to describe a large, ongoing, prospective study of buprenorphine discontinuation, and to discuss the ethical considerations involved in studying buprenorphine discontinuation. So why study something that we generally don't recommend? Most people who treat patients who are on buprenorphine recommend continuing it. Why would we study discontinuing it? It's because patients ask these two questions. At the beginning of treatment, they often ask, if I take buprenorphine, how long do I need to stay on it? And then if they're doing well for a while, they often ask, I've been on buprenorphine for a long time and I'm doing well. I'd like to see how I do without the medication. What are my odds of being able to do that? We don't really have great answers to that. We answer it, but there's a lot that we don't know. Many patients are either thinking about discontinuing or actually discontinuing. So 2 studies, one an Australian study showed that 62% of patients say that they want to stop using buprenorphine over the next 6 months. In a more recent study in the United States, 76% said they eventually want to stop, 9% were currently tapering. So patients are thinking about stopping very frequently. The United States National Academies of Sciences, Engineering, and Medicine addressed the first question, how long should people stay on buprenorphine? And they said the optimal duration of medication for opioid use disorder has not been established. All studies of tapering and discontinuation demonstrate very high rates of relapse, although some patients may be able to successfully taper off without a return to use. So some patients, how many patients, which patients, when and how, those are the things that we don't really know. We've got some information, which I'm going to be discussing. So what do we know? We know that stopping buprenorphine is very risky, with high rates of relapse to opioid use, increased mortality rate, higher overdose risk, higher risk of self-harm, and that we know that the first 4 weeks after discontinuation are particularly risky. But the studies that have shown all of the things that I just described are typically studies of very heterogeneous patients taking buprenorphine. And the numbers of all of the things that I just mentioned vary greatly by the setting and the population, because there are a number of different types of patients that are included in these studies. People who are forced to discontinue buprenorphine because they've violated some rule in a treatment program, such as selling their buprenorphine, something like that. People who stop without medical supervision, they just disappear and nobody knows what happened to them. And then there are some who voluntarily stop and are medically supervised as they do so. But also the studies that have been done on that talk about these things measure a variety of different outcomes: opioid abstinence, successful completion of treatment, overdose, emergency department visits, and some of the studies measure some and not others, so it's very hard to sort of look at all of these things. We know that some patients do well after discontinuing buprenorphine. What do we know about that? So in the prescription opioid addiction treatment study, which I led as part of the National Institute on Drug Abuse Clinical Trials Network, about longer ago than I care to mention, 12 years ago, with 600 plus patients at 10 sites, we examined different lengths of buprenorphine and different intensities of counseling, and that included a 42-month follow-up study. And as part of that follow-up study, we looked at patients at month 18 after entering the trial and month 42. And if you look at this, this is the percentage of patients at month 18 and 42 who were abstinent from illicit opioids in the month prior to that assessment, based on whether they were on agonists, which in this study was almost always buprenorphine, or not. And clearly, patients who were on agonists did better than people who were not on agonists, with 80% at both times being abstinent in the previous month. 37% at month 18 were abstinent without agonists, and 51% at month 42. So while agonists were clearly much better, there were plenty of patients who were doing well without them. What, in terms of current treatment, correlated with abstinence? The two things that we found, agonist treatment was the highest correlation, with odds ratios ranging from 3 to 5 based on the assessment, but also mutual help group attendance also correlated with abstinence, controlling for agonist treatment with odds ratios of 2 to 3. The RECOVER study was an 18-month follow-up of patients in a study of injectable buprenorphine, the Sublocade, who received up to 18 injections as part of the main study. During the follow-up, only about a quarter of them were still receiving buprenorphine, and approximately 2/3 of them reported past-week opioid abstinence at each of the 6-month follow-up visits. Whether or not they were receiving medication, there was no difference. Those who had received more injections during the main trial had a higher abstinence rate. Eastwood et al. And John Marsden, who's out there somewhere, was one of the authors of this study. A study in England, 54,000 patients who were on medications for opioid use disorder, a 5-year prospective cohort study of people who were in publicly funded treatments. 15% of them were still in treatment at 5 years. Their outcome measure was, quote, successful completion and no representation to treatment within 6 months. 22% achieved that, and the people who were most likely to achieve that were people who were older, employed at treatment initiation, and had stayed in treatment for at least 2 years. None of those are surprising, but it's good to see those. Bozinoff, in a Canadian study of 5,000 plus patients who tapered buprenorphine after at least 60 days of treatment. This was a retrospective 5-year study. Their primary outcome was overdose within 18 months after discontinuation. 13% experienced an overdose, and fewer overdoses occurred in people who had been on buprenorphine for at least a year, and for people who tapered slowly at a rate of 2 milligrams a month or less. In the United States, Robin Williams and his collaborators did a study of about 9,000 patients in publicly funded, Medicaid-funded treatment who had been on buprenorphine for ranging between 6 and 18 months and then discontinued. Those who had taken buprenorphine for 15 to 18 months before discontinuing had fewer adverse events than those taking buprenorphine for 6 to 9 months. However, in all of the cohorts, they measured 6 to 9, 10 to 12, 13 to 15, and 16 to 18. Those were the 4 cohorts. In all of them, more than 40% of them had emergency department visits. Overdose rate was more than 5% in the 6 months after discharge. So a lot of adverse events in that population. So what we can glean from these studies is that people who stay on longer and people who have the sort of characteristics that we usually think of as people doing better in opioid use disorder treatment, older patients, people who are employed, that those folks tend to do better. But most of these studies included heterogeneous populations, as I mentioned before, including a lot of people who discontinued buprenorphine early, many of whom were doing badly to begin with. There have been, up to now, no prospective studies that focus exclusively on patients who are stably treated with buprenorphine, doing well before attempting to discontinue. People who would ask that second question, I've been on this for a while, I'm doing well, what are the odds that I can get off this? So the optimizing retention and discontinuation strategies for OUD pharmacotherapy, or the RDD study, is a study that I'm co-leading with my collaborators, Ned Nunes from Columbia, John Rotrosen from New York University. It's a large trial at 18 sites funded by the U.S. HEAL initiative, standing for Help End Addiction Long Term, and the National Institute on Drug Abuse Clinical Trials Network. It's 2 studies combined into one, a retention phase designed to increase retention in opioid use disorder pharmacotherapy. I'm not going to focus on that today, and the discontinuation phase, and both studies are taking place at the same 18 sites. So the overview of the discontinuation study, it's the first prospective randomized controlled trial of buprenorphine discontinuation. Our charge, when we were asked to do this trial, was to design and conduct a randomized controlled trial to examine how long patients need to stay on buprenorphine. Our initial question was, how can we ethically study discontinuation of an effective, potentially life-saving treatment? So, thinking about ethics, the Belmont report, which we, at least in the United States, we all have to read before we can be in a research study on ethical principles and guidelines for the protection of human subjects of research, has 2 major foundational principles. One is respect for persons, and the other is beneficence. Respect for persons is acknowledging autonomy and protecting those with diminished autonomy, and beneficence is protecting patients from harm and securing their well-being. And so when we were designing this study, really what we were trying to do is to try to balance respect for autonomy and protection from harm. We were essentially allowing patients to make a risky decision, but trying to mitigate the risk. How did we mitigate the risk? In the informed consent, by emphasizing the risks, including relapse, overdose, and death, choosing a patient population that we believed was less at risk of relapse, meaning people who had an adequate duration of buprenorphine treatment and were clinically stable, very close monitoring and support, and stressing both to the clinicians in the study and the patients that the goal of this study is to avoid relapse, not to complete discontinuation of medication. So, key design decisions, we decided that randomizing patients to taper or not taper was unethical. And we thought that was really the only way to answer the question we were asked to answer, which is how long people need to be on medication, would be to randomize people who had been on different lengths. And we didn't feel that we could do that. We felt that the randomization had to focus on how to discontinue, not whether to discontinue, that we would not actively recruit study participants. We wouldn't say, would you like to discontinue your medication? Patients who had already made that decision would either be referred to us or come to us. So they had to self-identify as wanting to stop. We only enrolled stable patients, as I'll define in a minute, and we warned potential participants that this is risky. So choosing the population, the adequate duration of pharmacotherapy for people on buprenorphine, and that's virtually everyone in the trial, at least 1 year on buprenorphine. We're also looking at some people who are discontinuing extended-release naltrexone for people who've been on at least 6 months. And stability we defined as no opioid, cocaine, methamphetamine, or non-prescribed benzodiazepine in the previous 12 weeks, and no DSM-5 alcohol use disorder in the past 12 weeks. The design, participants entering on sublingual buprenorphine are randomized to a gradual sublingual taper, or, which is sort of treatment as usual, or extended release buprenorphine or Brixadi for a self-taper that we thought might give people a, quote, soft landing. All participants are also randomized. They receive whatever treatment as usual they're already getting, and they also are randomized to medical management alone or medical management plus the Connections app, a digital treatment which offers a menu of support options including networking and app-based cognitive behavioral therapy. People can taper for up to a year or more, and then we follow them for at least 24 weeks following the end of the taper. And our primary outcome is the percentage of patients who complete discontinuation without relapse to opioids in the next 6 months. Other possible outcomes are that they didn't, or that they completed discontinuation and relapsed, that they didn't complete discontinuation and relapsed in the middle of the taper, or that they did not complete discontinuation and did not relapse, which we consider a positive outcome. It's not just that you discontinued. Avoiding relapse is the outcome we clinically are looking for. The goals, the most important goal for us is to predict who can safely discontinue buprenorphine, to try to answer that first question based on really 3 domains: patient characteristics that preceded treatment, so their sociodemographics, the nature and severity of their opioid use disorder, for example, were they injecting or not, and psychiatric comorbidity, the duration of treatment before discontinuing to see if that actually is a key determinant, and then what we think is going to be the most important determinant, which is their clinical status at the beginning of the taper. How long had they been abstinent? Recovery capital, things like, do they have a job? Do they have a good place to live? Do they have relationships with people who don't use drugs, et cetera? Craving and distress tolerance. What we would love would be to be able to develop a metric or some sort of a score analogous to the way people stage, have staging scores for cancer, that you get a point for being employed, you get a point for having a high recovery capital score, you lose a point for having injected, et cetera. I don't know, it may be too ambitious, but that would be great. And then, of course, we're testing how to taper, both pharmacologic and behavioral methods, sublingual versus extended release, with and without the app. So the current status, we've already randomized 180 or so of the 310 that we're aiming for. Patients come in on a wide range of doses. We've had people who have entered on 1 milligram or less, people who have been tapering on their own and got stuck down there. And one of the recruiting challenges, we need, I mean, to some extent, a lot of these folks have to be referred by their prescriber. And so some people, the prescribers say, well, they're doing well by definition with me. Why would I refer them to somebody else? So that's been a little bit of an issue. And then patients, when they get there, a lot of them say, I only want the injection, or I don't want the injection, so they don't want to be randomized. And then some of them are just about to sign the consent form when they just say, I don't think I'm ready yet. Some of whom then come back a month or 2 months or 3 months or 4 months later and they say, I'm ready now. So anyway, that's, thank you to the National Institute on Drug Abuse and to my great colleagues at McLean Hospital, New York University, Columbia, MS, and NIDA. So thank you.
We prefer to make the discussion at the end of the symposium. The next speaker is coming from Australia, Sydney, Adrian DUNLOP, an old friend of Biarritz congresses and Europad Association. Long-acting depot buprénorphine in Australia, from clinical studies to clinical experience. Thank you.
Bon après-midi, c'est formidable d'être de retour ici dans cette très bonne conférence, Monsieur Jean-Pierre. Thank you. So I'm going to talk to you about the experience of long-acting dépôt buprénorphine in Australia over the last few years. There's my disclosures and acknowledgements. I'd also like to start just by acknowledging a great colleague, Professor Kypros Kypri, who very sadly passed away this weekend just gone. He was a fantastic alcohol researcher, a very wise epidemiologist, a behavioural scientist, and a great colleague, one of the kindest men I've ever met, and unfortunately he passed away. So I'd like to dedicate this presentation to him. So today I'd like to talk to you about buprenorphine and methadone treatment in Australia to, I guess, give a summary of how treatment is in Australia, what's similar or what's different to France, to talk about the long-acting buprenorphine clinical trials and implementation, and particularly some of the effects that were accelerated by the COVID pandemic. And then to, at the end, give you some clinical key issues that we see facing us with long-acting depot. So some background, methadone was established relatively early in Australia, since 1970 approximately. Sublingual buprenorphine in 2000, buprenorphine naloxone in 2006, and the long-acting formulations from 2019. And it's worth just saying at the start, so Australia has a mixed system delivery, including general practitioners and community pharmacies, but also including specialist clinics. And the model that was used for methadone back from the 1970s through the 1980s was also the model that was used for sublingual buprenorphine. So it's different to the situation in France, where any general practitioner can prescribe buprenorphine, for example. There's a dual system, a general practitioner system and a clinic system, and there are some limitations, so it's not easy for every medical practitioner to prescribe methadone or buprenorphine. There's currently about 56,000 patients in treatment, and so that's above 50% of the estimated number of heroin-dependent people being in treatment. There's about 3,000 people who prescribe. So of all general practitioners, it's very rare. It's less than 3% of all general practitioners, but similar to France, they do the bulk of the prescribing, and specialists account for about 20% of all the patients. There's about 2,500 community pharmacies that do dosing, and so that's where most of the community dosing happens, but clinics and prison have also been two very important places where people receive treatment. Again, similar to France, there's an ageing cohort. In fact, I think the median age is the same. 2/3 male, 12% First Nation people in Australia, so that's a significant overrepresentation, and generally unemployed. And for the patient at a public clinic, there's no cost. If they're seeing a general practitioner, there's often a cost per visit, so that would be something like €30 per visit to see a general practitioner. The dosing at a community pharmacy was much more expensive, but now is subsidised more effectively, and for somebody who's unemployed would cost maybe €5 to €9 per month for treatment. So just going back to what I was saying before, so Australia implemented the buprenorphine model, the sublingual buprenorphine model, similar to what had been done with methadone. So a high insistence on supervision. Most doses are supervised doses. Patients generally only become eligible for unsupervised doses once they've been in treatment for some time. And most patients are attending somewhere between 2 or 5 times a week for either methadone or buprenorphine to receive their doses. There's mandatory training for methadone. There was mandatory training for buprenorphine that's more recently being relaxed. Overall, treatment access is reasonable. It's good in the major cities. It's less good in rural areas. Counselling is not mandatory, so it's a low threshold treatment. And there are some other, important harm reduction interventions like naloxone nasal spray being provided free of charge to patients and family members. So there you can see the growth of treatment in this graph from the mid-1980s through to 2018. And you can see the treatment grew very quickly through the 1980s to the 1990s. And so fortunately it grew prior to a HIV epidemic, and in fact is one of the reasons responsible for there not being a HIV epidemic in injecting drug users in Australia. So there's never been more than, say, 2% HIV positivity in injecting drug users in Australia. So buprenorphine was introduced in 2000. You can see that's the orange part of the graph. It grew to about a third of treatment pretty quickly, but then stagnated after a period of time. So it established itself, but not incredibly rapidly. Then in 2019-2020, two formulations, so Buvidal, the weekly and the monthly formulation, and then shortly after Sublocade became available, administered by a nurse, pharmacist, including community pharmacist or doctor, subcutaneous injection, and it's subsidised similar to the other opiate forms of treatment, so there's not a cost disparity. Essentially how it works, once injected, the buprenorphine is mixed with excipients that form an outer layer covering the buprenorphine and then is slowly absorbed over a period of time. The excipients are slightly different in the different formulations. Very importantly, the rate of absorption of buprenorphine is different compared to sublingual. So you can see in the graph with sublingual buprenorphine, there's quite a rapid onset of buprenorphine availability in the hour or a couple of hours following administration. But with injection, and that's an example of a 16 milligram weekly injection, it's slower. So the peak is close to 12 to 24 hours. And it's, I won't present the data for Sublocade, but it's a similar sort of pattern and a similar sort of difference. And the important difference then being that rather having the daily peaks and trough fluctuations that you have with sublingual treatment, you get a slower decay in the amount of buprenorphine over a 1 week time or over a 1 month time, depending on the particular formulation. Here's a graph which tries to compare the bioavailability of the different formulations. So on your left, you'll see there's different strengths of sublingual buprenorphine from the 8 milligrams through to 32 milligram doses. The little white line in the middle of the graph is the average dose, and then the top number is the peak dose, and the bottom number is the trough dose. And then you can see through to the right-hand side of the graph some comparisons with Sublocade at different doses, the 100 and 300 milligram doses, and Buvidal weekly and Buvidal monthly. So in summary, you can see that there's some mimicking of the average levels and peak and trough levels by different formulations of buprenorphine, either weekly or monthly. So to talk to you now about the clinical trials in Australia. So we've had 4 trials. We've got ongoing trials at the moment. The first trial was a safety study. There were sites, of course, in North America and in Europe. There were 3 sites in Australia. And this was essentially a safety study. It had about 240 people overall. The second study was a randomised control trial in Australia in clinic settings. The third trial, a single-arm study of Sublocade. And the fourth study, a trial of patients being given Buvidal in prison settings. And to quickly summarise them, the study published in Addictions by Michael Frost and colleagues showed essentially good treatment retention at 26 weeks and 48 weeks, and overall adverse events similar to sublingual buprenorphine, but with the exception that being a parenteral medication, there are some side effects, generally mild, relating to having an injection. So it's common for people to have some discomfort, but generally that's not a problem for ongoing treatment. The debut study, that was a randomised study of depot buprenorphine compared to sublingual buprenorphine. The primary outcomes were patient satisfaction measures with the treatment satisfaction questionnaire for medication. And you can see that over a range of scores, global satisfaction, convenience, effectiveness, that depot-buprenorphine, long-acting buprenorphine, was superior to sublingual buprenorphine. Also some other important measures, patient global impression of improvement, treatment burden questionnaire, and quality of life. You can see as well there's advantages of depot over sublingual treatment. So this was important, I guess, for us to get some experience in clinical settings, but also to see that patients were telling us that they preferred this medication, and the strength, of course, being the randomised design. The CoLab study, so this was the single-arm study of Sublocade at, I think, about a dozen clinics in different states in Australia, and many of these clinical sites were in general practitioner settings, so that was an important experience of seeing general practitioners and community pharmacies work out how they could implement depot-buprenorphine. The difference in the colours is the two different doses, the 300 milligram dose and the 100 milligram dose. Interestingly, similar sorts of retention to the Frost study and to Nick Lanzeris's debut study, good retention at 26 weeks, or in this study also at 48 weeks. And then the last study, I'll talk a little bit more about this later today in a workshop. So the situation here was there was under-treatment of opiate dependence in custodial settings, and we had an opportunity to do a safety study, pre-registration of the medication in custodial settings in New South Wales in Australia. And this was offered to a group of patients who were opiate dependent but were not already getting treatment. And essentially we had very positive outcomes. So strong reduction in non-prescribed drug use, good patient satisfaction, and very importantly, some measures of healthcare costs, and healthcare costs of long-acting were about a third of that of methadone and about a tenth of sublingual buprenorphine. So good data for custodial staff in the prisons. So some of the important arms in implementing long-acting depot in Australia, one was to have clinical guidance. So this was available before the medication was generally available, and included, whatever published information we had, of different levels of evidence at the time, and expert committee, expert consensus where we didn't have evidence, which is, of course, many areas at the start of treatment, especially back in 2019. Very available and flexible training programs, so online or face-to-face training programs that could be delivered or repeated. Train-the-trainer models were used, so we had good coverage of that. Consumer information, so consumer groups were involved in developing consumer information about depot-buprenorphine. And at the same time, we had a prescription monitoring system that didn't initially include depot-buprenorphine, but did give us more up-to-date data about other non-medical opiate use, or other prescribed opiate use rather, in Australia. So yeah, these, I guess, are some of the key parts of making it available. It was available at the same time to general practitioners and addiction specialists, so it was not just addiction specialists first. Administration could be in public clinics or at a general practitioner's surgery or in a community pharmacy, and the cost was subsidised, so there wasn't a price gradient for patients wanting this sort of treatment. There's a shot of the guidelines. They're currently being updated, and the updated version will be available later this year. So they cover things like how to start a patient on Buvidal either weekly or monthly, how to do a swap from sublingual treatment, how to swap between weekly and monthly treatment. They cover induction onto Sublocade, again, how to start a patient, periods of time of sublingual treatment first, the 300, 100 milligram dosing regimen. And then, of course, we had really significant changes in our treatment system, like everybody did in the world, due to COVID. So we had to have a rapid move away from supervised dosing during the pandemic. We didn't want queues of patients queuing up for methadone or sublingual buprenorphine. We had to rapidly move to telehealth. And in particular, in the custodial system, there was an enormous surge in demand for treatment, probably because trafficking of illicit sublingual buprenorphine, which is the main illicit substance in prisons in Australia, it almost dried up totally. So there was an incredible wave of people withdrawing from opioids in prisons and a demand for treatment. Other important changes, I think, has been the availability of long-acting buprenorphine in rural towns where previously there might not be a pharmacy that provided sublingual methadone or buprenorphine, or it's too small to have a clinic. So now, just to give you an update, what's happened since 2018. So these are numbers just for buprenorphine, doesn't include methadone. You'll see that the sublingual is in the green and the long-acting is in the blue. And so within 3 years of implementation, or even a bit less, you can see that in December last year, long-acting became over 50% of all buprenorphine prescription. And again, just to stress, this is mainly driven by patient demand. There are also system factors such as the custodial system preferring to put people on long-acting rather than any other sort of treatment, but the rest of it is driven by patient demand. So now just over a quarter of all treatment is long-acting treatment, and methadone is less than 50% now. So just to run through a few sort of important, interesting clinical situations, I guess with a few years of experience, we tend to do much less stabilising patients on sublingual treatment before starting Buvidal weekly, and are much more comfortable with inducting patients directly onto Buvidal weekly. Indeed, there's situations where, say in rural areas where we have very limited staff, we might need to induct patients onto Buvidal monthly because that's all that's available in terms of clinical services, and we're becoming more familiar with that, so that's important. A key issue is that it's very uncommon to see precipitated withdrawal with starting patients on long-acting buprenorphine, and that may relate to this sort of rate of onset of buprenorphine compared to sublingual treatment. Questions about who's it for? I think like anything new at the start, we reserved this for our most stable patients and the patients that we had the fewest concern about. Over time, I think that's switched, and we now believe that it should be an equal first line for treatment alongside sublingual buprenorphine and alongside methadone. And indeed, there's some patients who, for various reasons, seem to prefer this treatment, patients who might not have stable housing or be able to attend a clinic regularly. In terms of transferring from methadone, so this is also in our guidelines. We needed to do more of that during the pandemic, when again patients wanted to swap from methadone treatment to depot buprenorphine treatment, so they had less requirements for attendance at a clinic. Of course, it's possible for patients on lower doses of methadone, 40 milligrams, 30 milligrams or less, to directly swap to Buvidal weekly. There is the possibility of gradually reducing patients on higher doses, so above 40 milligrams slowly to 40 milligrams, and then doing a swap via sublingual, but also increasingly other methods such as the microdose or Bernese method are used, where you taper a patient's dose of methadone while at the same time starting at a microgram dose of sublingual buprenorphine, and then sort of increase over different periods of time, could be a week or so. So more experience with that, or also using a bridging method where you stop methadone and then have a few days of another opioid such as oxycodone, and start directly onto Buvidal weekly. So the guidelines cover these different situations. Pregnancy is an interesting one, and of course, talking to a French audience who had the first large publication of buprenorphine in pregnancy back in the early 2000s. I don't think there's much new to say here. Of course, buprenorphine is buprenorphine, and so buprenorphine is now definitely shown to be safe and effective in pregnancy, and indeed probably has some advantages over methadone treatment. Long-acting may have even more advantages, not yet established, but theoretically might have advantages due to more stable blood levels maternally. There's less norbuprenorphine in long-acting, or in the metabolism of long-acting, compared to sublingual, and there's a theory that this might be less associated with neonatal withdrawal. And excipients are generally metabolized quite rapidly, so that doesn't seem to be a concern. There's an RCT in the US that I understand has been completed, but data's not yet available, but so that will provide some very important information about the efficacy of weekly depot treatment compared to sublingual. And so our local guidelines recommend continuation if the patient's already stable on depot treatment. And then stopping treatment, yeah, very interested to hear my colleague's previous presentation, and it'll be great to see the data from that. In terms of our guidelines, because we have people wanting to withdraw from treatment all of the time, we recommend not switching patients to sublingual and stopping the depot treatment. There's an ongoing case series that we're collecting data from. The early data from that seems to suggest that patients may experience withdrawal, but not till several half-lives after the long-acting has been ceased. So for a patient on monthly, that might be somewhere around the 12-week period of time. And withdrawal does not seem to be the same sort of classical withdrawal that you see on patients stopping methadone or sublingual buprenorphine or heroin, that sort of crescendo, decrescendo over a week or so. It seems to be much more transient, it comes and goes, and symptoms don't appear to be that severe. But of course, we need more data to be confident of that. An interesting idea that we haven't yet tested is short-term use for withdrawal treatment. So in Australia, it's common to use this sort of crescendo, decrescendo pattern of prescribing, going, say, up to 8, 10, 12 milligrams and then decreasing over a 5-day period. Of course, a depot injection, a single depot injection mimics that with much more, fewer peaks and troughs than injection of depot. So maybe that's going to be useful and certainly something that warrants study. But probably more important, it makes the transition between withdrawal treatment or transfer of the concept of withdrawal treatment to ongoing treatment very, very easy. And often practically we see patients who come in and at the start say to us they want withdrawal treatment, but then decide that they want maintenance treatment, and that's a very easy switch to do. So in summary, long-acting depot, a rapid and very significant change in treatment in Australia. A quarter of all patients now in Australia on this treatment after just over 3 years of implementation. It appears likely that there'll be further uptake. I guess key drivers are having a system ready to go, having training ready to go, not making hard for practitioners to prescribe, to make it available by general practitioners and community pharmacists as well as clinics. Having local data on patient demand for treatment, so understanding patient satisfaction has been very important. And certainly very important to be able to have an option for less stable treatments. Still plenty of questions to answer, including these issues of coming off treatment, withdrawal and pregnancy. Thank you very much.
Merci beaucoup, Adrian, pour cette présentation qui va certainement susciter des questions. On va passer à la deuxième partie maintenant du symposium avec John Marsden qui a préparé une présentation qu'on va lancer dans un instant. John Marsden est professeur de psychologie au département d'addictologie et l'Institut de psychiatrie au King's College à Londres. Il est impliqué donc d'une étude qu'il va nous présenter, dont le titre est « La buprénorphine à libération prolongée pour le traitement des troubles liés à l'usage des opioïdes par rapport au traitement quotidien standard », résultat de la première étude d'efficacité en face à face. Donc, vous voyez, après l'expérience américaine, l'expérience australienne, maintenant l'expérience britannique. John Marsden, the floor is yours.
Hello everyone, greetings from London. I'm absolutely delighted and honoured to participate in today's second plenary at this important meeting in Biarritz. My apologies for not being able to join you in person. The title of my talk is Extended Release Buprenorphine for Opioid Use Disorder versus the Daily Standard of Care. I'm going to be presenting headline findings from the first head-to-head superiority randomized controlled trial called EXPO, conducted here in the UK. I have some affiliations, disclosures, and an acknowledgement. You can see the first two on this slide, and I'd like to kindly acknowledge that the EXPO study was funded by a a collaborative research agreement with Indivior. Indivior met our research costs and also provided US Sublocade for our trial, which at the time of the study was not available in the UK. Study sponsor was King's College London and the South London and Maudsley NHS Trust. All studies have an important contextual background, don't they? And the motivations for running a study and how the findings can be interpreted have to be considered in the light of the aspect of opioid use disorder pertaining to a particular country at a particular point in time. If our study was done in North America, it would look very different in terms of its patient population. In the UK, at least at the moment, the epidemic of opioid use disorder essentially relates to heroin, but we do have a very high level of prevalence of cocaine use disorder, as you'll see as I speak today. We have a treatment population of about 70,000 or so people with heroin opioid use disorder, 7,000 or so people who have an addiction to the alkaloid smokable form of cocaine crack, and most importantly, perhaps for the presentation today, another group of 71 or so thousand people who have an addiction to both opioids and cocaine. And there are strong instrumental links for many people who use opioids and cocaine sequentially or concurrently. Opioid agonist treatment as one of the main first-line therapies for opioid use disorder has served us extremely well over many decades. It does have some limitations, and these are just fragments from a very large literature that addresses some of the reasons for concern and to motivate studies to improve engagement and efficacy. So the first summary, as you can see, is the statement that many of our patients don't stay for as long as they or we would hope. In one study that we did in England, nearly 40% had left by 12 weeks, and that retention rate can actually be worse in other particular jurisdictions across the world. Early non-response clinically often predicts quite strongly continued non-response. The prescription opioid study conducted by Roger Weiss and his team captured a sense of early non-response after as little as 14 days, and that predicted non-response up to 3 months later. In our country, we've often been motivated to retain people in treatment. Our retention rates are overall not that bad, but response is not as optimal as we would like. So in another study of 21 or so thousand people, just 37% were absent after 6 months of treatment. And that was moderated, as you can see, if cocaine was also used at admission. And then even among the people who stay in treatment for very long term, non-response is also quite common as well. This is a quite understudied area. And we looked at 8,000 or so people that never left OAT for 5 years. 15% started well, but then relapsed within treatment after 6 months, and a further 5 did well, but then seemed to run out of change steam, if you like, after 2.5 years, staying for 5 years, but really continuing to use heroin on around 50% of the days in each month for each half-yearly clinical review. So taken together, there's lots of reasons to support our first line, but also lots of motivation to look for ways of strengthening it. Extended-release buprénorphine has been a very welcome addition in terms of investigational and now licensed products to our standard of care. We've got 3 contenders in the history, a subdermal implant, prolongée, which has now been removed from the market. I believe the company are now pursuing a chronic pain indication. So the focus really clinically for us internationally is on the Camurus product, so that's a weekly and a monthly subcutaneous injection, and the monthly subcutaneous injection developed by Indivior, with various labels in terms of brand name for various jurisdictions. And I'm going to be focusing on the Indivior product today, and I'll be reflecting on the comparison of that medication against our standard of care. And just to remind us all, but in particular in the UK, we are looking at methadone, a full mu opioid receptor agonist, and the various formulations of transmucosal buprénorphine, sublingual tablet, a tablet and polymer film, and a lyophilized wafer. But I'll talk about, if I do mention them in passing, I'll talk about BUP-SL as the catch-all for all of the buprénorphine standard of cares. So when we were thinking about the study, our motivation was to reflect on what a long-acting injectable formulation might achieve. Could it break the cycle of perceived stigmatized attendance for pharmacy dosing? Not everyone experiences that, but some patients, when asked, note that they don't feel very comfortable about attending in line to have their oral medication supervised, and they do sometimes cite that as a motivation for leaving treatment. So it could break the cycle of that by simple monthly dosing. Could it achieve opioid blockade and give control of craving and stem any subjective effects of opioid use and really provide a very therapeutic platform for recovery? There's been lots of qualitative studies done, and quite a few done before our trial, that gave us a sense that patients among those who wish to try this medication strongly endorsed that opportunity. But we also felt that this would be an option for some, but not for all. It felt, even at the beginning of when we were planning the trial, that some patients would naturally want a full agonist, and others would not like to relinquish, if you will, control over the choice of taking any medication that was dispensed to them for home administration. So in summary, the subdermal is now discontinued. I haven't looked recently whether it's emerged again, but when I put these slides together a short while ago, that was the case. 2 long-acting products from Camurus and from Indivior. There's been non-inferiority evidence for the Camurus product, which has helped achieve license, but no efficacy superiority evaluation of the Indivior product, and that was our motivation to conduct the trial in the UK. Expo was done in 4 sites in England, in our coordinating centre in London, and then moving up the country in the Birmingham, West Midlands area, the Manchester metropolitan area, over the Pennines to the north, Newcastle, and then over into Scotland in Dundee. And those are all areas with very long-standing populations affected by illicit drugs, in particular heroin and crack, and with equally long-standing community setting, National Health Service, secondary care clinics. So all of these recruiting centres for Expo were routine, day-to-day operating NHS clinics. We tend to try and do our trials in my group that are based in real-life clinics, as you will, to maximise generalisability of findings. I've got a long list of investigators, service user representatives, researchers and analysts that I'd like to acknowledge from the research team. So getting down to business, this was a 24-week open label RCT. We compared all forms of standard of care. So we recruited patients who could be on all forms of, or any of the forms of buprénorphine or methadone at any dose level. So it was very, very routine, sort of natural study with no investigational control over that. So standard of care. Versus Sublocade. So US stock Sublocade, I'll mention that in a moment. We followed mainly the label with one exception. So we've got the 2 loading doses. We allowed patients to come in at a minimum of 21 days rather than 26 to just a month or so days after first dosing, just to maximize the opportunity for patients to have flexibility so that we could achieve loading dose administration. And then for the 6 months, we've got a maintenance phase in which it's monthly 100 milligrams or 300, determined by safety, preference, and control of symptoms. And we offered rescue sublingual buprénorphine at any time. So as you can see there, there's going to be, in the design here, a transition from patients previously on methadone if randomized to Sublocade, and also if randomized to standard of care patients who would stay on methadone. We powered the study for 300 or so participants for a primary outcome that I'm going to spend most of my time on. In the end, we randomized 314 people to the standard of care or Sublocade. Primary endpoint was abstinence for opioids over 24 weeks, and that gave us our superiority effect. A fair stack of secondary endpoints, exploratory, craving, retention, various scales. I'm only going to talk to a couple today at the meeting. We did an economic cost-utility analysis, and that's for another day, just in terms of time, and several qualitative studies, including receipt of the injection up to 18 months, which sort of marked the end of study. So we were able to invite people to have longer injection therapies if they chose to after graduating our 24-week endpoint. Medication supply, as I mentioned, it originated in US stock, and Amory worked with us releasing Sublocade to Sharp in the US. They then put that in the belly of actually I was about to say a 747, I think they've gone out of service now, but some aircraft anyway. And that came into Wales in the UK. And then with cold chain distribution to hospital pharmacies, we used local transit and then controlled drug clinic storage for administration to patients. The IMP, the investigational medicinal product, as you can see, is cold chain, so we brought it to room temperature over a quarter of an hour. We modified our protocol a little bit so that if a patient decided they didn't want dosing, which is very rare, we could twice refrigerate unused stock rather than destroying it. The dosing schedule was reasonably unremarkable in that we've got a flexible window, which is one of the great benefits, in my personal opinion, about this particular intervention. It's got a great flexibility for patients. You can see of the 6 injections, the 2 loading doses and the 4 maintenance doses, quite a wide window. For the second dose, as I mentioned, a minimum of 21 days. But look at those upper windows. That gives our patients a lot of flexibility. Some patients with OUD do struggle to schedule their time. And so this opportunity to, when a patient attends a clinic, to receive their dosing within their protocol window was a good benefit. I'll move on to tell you a little bit about receipt of injections in a moment. The figure on the right of the slide just shows you that we move around the compass points from the northwest, northeast, southeast, and southwest quadrants each month. So just a few slides about who was eligible, who took part, and what did they receive, focusing on the standard of care and the injection. So study with adults, they had all DSM-5 OUD at a level of at least moderate severity at the admission to episode. Our studies in the UK are often done with patients who, if they meet criteria, can be in treatment as well as newly admitted to it. And that, I think, reflects, I hope, the slide I showed you at the beginning, that we retain people reasonably well, even if they're not responding as well as they would like. So we opened it to really anyone who met the criteria of wanting to take part, who had that severity at admission. We required them to be able to convert to Sublocade within a week, and the usual exclusion criteria is that you might expect a study like this to implement. So we identified 1,700 or so people. We excluded a fair number who, I won't get into some of the scheduling of doses, but there was a reasonable number excluded because they were on a relatively high dose of methadone and couldn't convert in time. But we found 386 people who were eligible and 365 of whom were enrolled. 346 randomly allocated to the two groups that you can see there. So reasonably balanced, stratified by various factors as you'd expect. There was a small nested study in London. In the event, just 32 people were randomized to receive the oral daily of care plus a personalized psychosocial intervention, or Subutex and or Sublocade and a PSI. To be honest, we sacrificed that on the altar of recruitment priority during COVID, and we're going to be analysing the data for that as part of a qualitative evaluation. But we diverted what would have been randomised cases to that sub-study to the head-to-head. So the analysis set is 314 patients. A fairly unremarkable sample of patients, given what I've talked about a moment ago about new and existing. The average age, 40 years or so, majority indicating their ethnic origin to be white UK, 74% in maintenance OAT enrollment, 44% using heroin in the last month, 50% using crack cocaine in the last month, well over a fifth using non-medical benzodiazepines, 9% non-medical injecting. That injecting percentage is lower than one might see perhaps at admission in the studies in perhaps the US or Australia, but reflects the idea, I think, of a harm reduction benefit for those who are recruited from treatment episodes ongoing. So, findings. First of all, the vast majority of people who were randomized to continue in standard of care received their allocated treatment. So 155 of 156 received at least 1 day of oral daily standard of care medication. In that arm, 46% did not complete follow-up, so they discontinued treatment before 6 months. And 1 in 5 or so had at least one restart. Starting and stopping is a very common phenomenon in the UK, I'm sure globally. We spend a lot of our time safely restarting a patient that has not collected their medication from a pharmacy. So the restart rate there was 21%, and there were 56 restarts overall. And quite a strong comparison with the injections. So 95% received their allocated treatment, 29% didn't complete follow-up, so a greater proportion completing all days of treatment to 6 months. But some restarts, but just 11% rather than 21%, and that was a smaller number overall, 21 in total. This is a heat map for the injection of buprénorphine among the 158 people that were offered it. The 6 injections are stacked as bars. It's very difficult to see, but each blurry row is a patient. And we've ranked the data by completeness, if you will, of adherence to the 6 injections. So a black row is the 300 milligram loading dose. A blue row is a 100 milligram maintenance dose. And a grey row is a missed dose or no dose because the person has left treatment. So you can see there's a sort of small grey bite out of the bottom of the chart which indicates discontinuation. Very little grey bars among people who are enrolled in treatment and retained to the end point. And the takeaway from this slide is that there was great adherence to the injection. The mean number of injections received was 5 or so out of 6. 70% received all 6 injections, and the most common dosing profile was the protocol sequence. So that's the 2 by 300 milligrams and the 4 by 100 milligrams. 68% of participants received that. There were some variations that we were keen to offer to patients. So 11 people just received 3 300 milligram shots and then 3 100. Just 4 people had full 6 by 300 milligrams, and then there was a fairly complex mixed pattern among the remainder. So our primary outcome, as I mentioned, was opioid abstinence, and there's various ways you can do that. The field still lacks a gold standard. My group has its preference, which is to count every day using a timeline follow-back approach with urine point-of-care drug screening data as well. The thing about a monthly injection is that it doesn't really make a great deal of sense to require a person to come in thrice weekly, twice a week, even weekly perhaps, if you're offering them the benefit of a monthly injection. And we felt like a 2-weekly clinic visit focusing on safety, completion of research measures would be acceptable, and indeed it was. So over the 6 months of the study, the 24 weeks, you can see randomization. There was then a grace period. We had a 7-day grace period that we used so that we would be counting the start of treatment at the same point. So it enabled people to have their injection so that we could count the days after that for the 2 arms together. We also looked at the grace period as well, as you'd expect. So our outcome measure is a count of days, ranging from weeks 2 to 24, and that's day 8 to 168. We measured it by timeline follow-back. The recall period was 14 days. It could be up to 90 days on the rare occasion that someone just couldn't come in until sort of maximum recall period for the timeline follow-back. But most commonly it was done for a reasonably short recall period. We used a standard urine drug screening at each of the visits, so that's 12 tests, and the UDS kind of trumped self-report. If the UDS was positive for opioids on the day of the test, we marked that day positive and the previous 2 days. And we did various sensitivities that checked on if you like, the algorithm for that, which I won't talk about today, but didn't affect in any way the outcome that I'll get to. So our primary outcome measure ranges from 0 to 161 days. We also looked at longest duration of continuous abstinence as a linked secondary, as you can see at the bottom. So I want to just talk about treatment response. So if you imagine we've got 6 months, just because it won't fit onto one slide, let's just say we've got 28 days, and so we've got 6 of these lined up, one after the other. But we've got 28 days in that 4-week block, and let's imagine that the patient abstains for each day. So we could use a data visualization to show that that was a line of green squares. On the other hand, if they used opioids on each day, it would, for example, be shown as red, or some other color, but I've gone for red here. There could be a mixed pattern. So let's imagine this is at the beginning of treatment. The person might actually sort of test their blockade effect, for example, if they got the injection and used heroin, but then didn't for a while, and did and didn't and did and didn't. So a mixed pattern. And then finally, there could be a mixed pattern in which we've got periods of days of missing data among people that are in treatment, and also those who are providing data to the point where they leave treatment, and the data after that is missing due to discontinuation. I've become a real fan of data visualization using techniques like this. I think it, at a patient level, in spite of all the possibly complex statistics that we do to model correlated data from multi-centered trials, there's nothing better than a data visualization technique. So I want to just show you this one for the longitudinal course of opioid use for the comparison group. So this is a heat map. It looks a little bit like the heat map to the injections in the way that it's similar. We're now looking at 24 weeks of treatment along the x-axis by day, so it's impossible for anyone to see the individual squares that are days. On the y-axis, we've got every patient randomized to the standard of care. So you'll recall that's 156 people. And we've used those three colours. We've used green, red, and grey to denote the longitudinal course of opioid use. So each row is the data from one participant. This is unadjusted participant-level data. But we've organised the data by the number of days collected and ranked it in a decreasing way, by the number of days abstinent, also whether the endpoint day was collected. There's a black vertical line, which is the 1 week grace point. So green is a day of abstinence, red is a day of opioid use, grey denotes no data, usually due to discontinuation. So what you can see is a kind of report card, data visualization for standard of care. And it looks pretty good to me in a way. You've got quite a sizable group of patients fully retained and abstaining. We then meet a group of patients that are equally retained, but they use heroin occasionally. There's a temptation to stare into that data visualization and see repeating patterns. I've done that for more time than I probably should care to admit to you. You'll notice, if you can see, there's then a couple of patients who are giving quite a lot of in-treatment missing data. So they didn't attend really, or refused. There's then a red waistband, isn't there, right in the middle. And that's a group of patients that were retained continuously, but used heroin continuously on every day. We then got the big grey chunk out the bottom, which is discontinuation. And the response profile among people that didn't stay for 6 months is variable. There's a few that are abstaining, there's a few that are using fairly continuously, and a few that use intermittently. But it's not bad, and it is the standard of care, and that's why we use it. So the heat map shows a group of patients retained and abstinent, a larger group retained but with sporadic repeating use, a smaller group retained but stably non-responding, and then a mixed pattern among people who discontinued. So the thing to do then is to compare that chart visually with the one for the buprenorphine extended release Sublocade. And you can see it's very, very dramatically different. So the structure of the chart is identical. So 24 weeks, 158 people this time, so just 2 more, slightly longer height. But it shows a much larger group of patients retained and completely abstinent, a larger group of people retained but using sporadically, much less often, a smaller group retained and stably non-responding. So there is a waistband, but it's only really 1 or 2 people that are continually non-responding. And then a mostly abstinent pattern of response before any treatment discontinuation. And you can see there's a smaller bite out of the chart to indicate discontinuation. And if we put them side by side, it really is quite a dramatic effect. As you'd expect, there is an adjusted treatment effect in favour of Sublocade for the primary endpoint, also for the continuous abstinence measure, and as you might expect, for retention as well. Opioid craving was certainly reduced quite dramatically among people that experienced some craving. We also found quite a strong footprint of effect in which the craving measure we used returned a 0 response from patients that said, look, I haven't craved at all, but I'm just going to graph here the numbers for patients that returned in each research visit a non-zero response. But you can see a very strong separation in favour of the buprenorphine extended release arm, with the orange bars showing lower craving consistently right the way through to endpoints, and no overlapping of error bars. We had expected that cocaine might be decoupled to some extent, but we found no evidence of that in the trial. So the mean days of abstinence for cocaine was quite high. It is a very streaky, episodic drug affecting people, not far from continuously, but often in very strong, intense period episodes. But no statistically significant signal in favour of the injection. And cocaine frequency, as you can see, really just doesn't separate in the way that it does for opioids. So finally, and to close, summary-wise, we had more opioid abstinence in the injection, longer periods of continuous abstinence, longer time enrolled in treatment, less craving. We're going to be using a time-varying effect model set up to analyze that for evidence of mediation, but no detected impact on cocaine use and craving. So, subcutaneous long-acting buprenorphine is an effective intervention, and it's a welcome addition to our toolkit of OED interventions. There's many questions that are under evaluation and need addressing, longer-term outcomes, the use of BUP-XR as a taper. In the UK, dual OUD-CUD is prevalent, and our study shows cocaine use to be fairly unresponsive. And our next target is polypharmacy for those dual patients who we would offer standard of care, including the injection, and then experimental medications, perhaps two, for cocaine use. So on that note, thank you ever so much for allowing me to participate like this at the meeting. If anyone is interested, we've got a protocol published in Trials, and the headline results that I presented today should be available in a peer-reviewed scientific journal in now just a few days. We're just sort of correcting typos and so forth. Thank you ever so much.
Bien, alors pour terminer cette session internationale sur les long-acting, nous avons le plaisir d'accueillir Alice Deschenaux, qui est psychiatre addictologue à l'hôpital Paul Guiraud, Paris-Villejuif, et qui va nous... Je crois que, Alice, tu as la plus grosse cohorte hors prison de patients sous Vidal, je crois. En tout cas, tu vas nous en faire profiter avec le titre de ta présentation, prise en charge de la dépendance aux opioïdes en vie réelle par un traitement dépôt sous-cutané de buprénorphine d'action prolongée, étude OPALE 2.
Merci Maurice. Bon, je pense qu'on est maintenant... beaucoup plus nombreux hors des prisons aussi à prescrire, et donc c'est pourquoi on peut, justement, je peux aujourd'hui venir présenter un travail multicentrique, et donc qui concerne plusieurs structures françaises qui ont contribué à cette étude OPALE 2 sur la prise en charge de la dépendance aux opioïdes en vie réelle par le traitement buprénorphine sous-cutané en dépôt, donc la forme d'action prolongée. Alors, pour passer, c'est là, voilà. Donc, les liens d'intérêt concernent beaucoup l'industrie pharmaceutique dans le secteur concerné. Et donc, pour revenir sinon à l'objet du jour, bon, petit rappel rapide, on a parlé de différents pays. En France, on a la forme Buvidal, qui est donc une solution en injection sous-cutanée de buprénorphine à libération prolongée, qui est indiquée chez nous à partir de 16 ans, donc chez l'adolescent et l'adulte, sous la condition d'avoir une dépendance aux opioïdes, sans autres critères d'indication. Et tout cela grâce à une AMM qui date de mars 2018 maintenant, un avis de l'HAS qui est arrivé en France en mars 2021 et qui a permis la mise sur le marché, et donc le démarrage de l'utilisation en France à partir de cette date. Et un petit point de précision que sur le dosage 160 mg qui ne faisait pas l'objet de cette commercialisation initialement, et qu'il n'a donc été que dans un deuxième temps, et en fait récemment, puisque c'est cette année, en février 2023. Et donc, on est évidemment donc très intéressés, nous, sur la question des données en vie réelle en France, puisqu'on a effectivement des publications qui se multiplient du côté anglo-saxon et dans un cadre de prescription qui reste assez différent aussi. Et donc, c'est tout l'intérêt qu'on regarde aussi ce qui se passe chez nous, et puis qu'on puisse se comparer et questionner nos modalités nos modèles de prescription, de dispensation, nos critères d'usage. Alors, quelques mots sur le design de l'étude. Il fait suite, en fait, à un travail qu'on avait eu le plaisir de pouvoir mener à Paul Guiraud sur 34 de nos patients, qui étaient les tout premiers patients qu'on avait eus et qu'on a pu faire après 6 mois de démarrage, et donc étaient monocentriques, et qui étaient aussi rétrospectifs. Et donc, à partir déjà de ce travail, a émergé le projet de poursuivre en reprenant un petit peu le design, mais dans l'objectif surtout d'être multicentrique et de permettre permettent donc d'avoir plusieurs modalités de prescription, de travail. Donc l'objectif principal, c'est estimer le taux de rétention sous buvidal à 6 mois. On a un peu parlé dans d'autres présentations sur d'autres pays, en conditions réelles en France, avec évidemment le souhait aussi de voir s'il y a des profils de patients, de patients concernés par la prescription, mais surtout aussi par cette rétention sous traitement à 6 mois, les modalités d'utilisation, l'expérience patient, l'évolution des comportements à risque et les facteurs qui pourraient donc être associés à cette rétention à 6 mois. L'étude concernait des patients majeurs qui avaient donc une dépendance, enfin un trouble de l'usage des opiacés, qui avaient initié le buvidal depuis au moins 6 mois, qui a exclu tous ceux qui avaient été inclus dans OPALE 1, et qui était donc une étude rétrospective qui impliquait d'aller chercher les données dans les dossiers médicaux des différents centres. Et cette étude a précisé que Camurus est donc le promoteur de l'étude et qu'elle a été réalisée sur le plan méthodologique et du recueil de données avec Capa Santé. Alors c'est une analyse de données intermédiaire que je vous présente aujourd'hui. Comme toujours, ça ne va pas toujours aussi vite qu'on le voudrait. Donc on est sur les résultats qu'on a à la date du 30 septembre 2023, avec 9 centres sur les 12 inclus qui ont pu être intégrés à cette date. Et on est à 53 patients sur une cible, 53 patients, c'est ceux qui sont toujours sous traitement, excusez-moi, on est à 73 patients qui ont été inclus sur une cible d'une centaine. Et sur ces 73 patients inclus qui ont reçu donc au moins une dose, on est à 53 personnes qui sont toujours traitées à 6 mois, c'est-à-dire à 72,6% de taux de rétention. Pour observer un petit peu mieux ce taux de rétention, je vous propose de regarder cette courbe de Kaplan-Meier qui vous permet de voir, alors si je trouve, voilà, ici vous êtes en mois 1, et donc vous voyez à 1 mois ici, et donc on va dire même à peu près entre 1 et 2 mois, qu'on a un quart à peu près des personnes qui ont quitté le buvidal, qui ont arrêté, et puis ensuite quelque chose qui va plus doucement. Et on va le voir aussi dans les données suivantes où on a, je vous ai laissé les moyennes et médianes sur la durée de traitement sous buvidal pour les personnes qui ont arrêté au cours de ces 6 mois. Et donc vous voyez qu'on a une médiane qui est un tout petit peu au-dessus d'1 mois et une moyenne à 1,4 mois. Sur les motifs d'arrêt, je vous les ai indiqués juste en dessous. Pour la plupart des patients, on parlait d'une décision, donc sans forcément préciser pourquoi, mais juste de se positionner comme souhaitant arrêter. D'autres ont donné un peu plus de précision. 5 se sont plaints d'un manque d'efficacité. 3 des problèmes de douleur sur les injections. Et puis on voit aussi qu'il y a du circonstanciel, un départ de médecin référent, une incarcération, un perdu de vue. Une personne qui a fait part de son inquiétude à passer au mensuel, et puis pour 7, on n'avait pas les informations précises, et donc certains évidemment exprimaient plusieurs donc raisons à l'arrêt. C'est pour ça que vous avez autant de raisons. Pardon. Sur l'analyse de données intermédiaires concernant maintenant des données alors un peu croisées, c'est-à-dire que plutôt que de vous mettre les données sociodémographiques et après de vous dire s'il y a une différence ou pas entre ceux qui ont arrêté et ceux qui ont continué, je vous ai proposé d'intégrer tout de suite dans un tableau les différents groupes. Donc sur cette série de tableaux qu'on va avoir, vous avez une première colonne avec les patients qui ont arrêté le traitement avant les 6 mois, des personnes toujours traitées à 6 mois, donc les 53, et puis la population globale d'analyse. Sur des données sociodémographiques qui concernaient le genre ou la situation professionnelle, la situation maritale, parentale, le niveau scolaire, il n'y avait pas de différence entre les groupes. Et la seule qu'on a retrouvée, c'est la différence en âge avec des personnes qui étaient un peu plus âgées dans ceux qui ont poursuivi le traitement. Ensuite, si on regarde les comorbidités, ça c'est au moment de la mise sous traitement, dans les comorbidités qui étaient connues. Donc on retrouve la présence, dans les 2 cas, dans tous les groupes, une forte présence d'au moins une comorbidité active. Donc là, ça comprend le somatique et le psychiatrique. Le psychiatrique, ici, au moins une comorbidité psy, c'est en bas. Et là aussi, vous voyez, pas de distinction, en tout cas, qu'on pouvait retrouver, nous, à cette échelle, dans ce groupe. Et puis, on a recherché quelques comorbidités spécifiques, les maladies infectieuses, certaines pathologies psychiatriques, en particulier les comorbidités algiques. Là, on n'est pas significatif, mais c'est une donnée qu'on ira un peu plus observer avec un peu plus de patients. Et peut-être contrairement parfois à certaines idées reçues, eh bien, il y avait plus de personnes douloureuses dans ceux qui ont poursuivi que dans ceux qui n'ont pas poursuivi. Pour ce qui concernait les consommations, cette fois, à l'induction, vous voyez qu'il n'y avait que 16% de personnes qui ne consommaient aucun produit, si je regarde la population d'ensemble. Et ensuite, eh bien, ça se répartissait quand même pas mal entre des usages de 1 à 2 substances, 3 à 4 substances, et même plus de 4 pour 1/5 des personnes. On n'avait pas, nous, à ce niveau-là de différence significative. Quand on détaillait le type de produit, c'est là que sur cet effectif de 73, on retrouve quand même un petit peu à 0,02 pour la cocaïne crack, avec beaucoup plus de personnes usagères, pour le coup, dans la population qui a arrêté. Et si on regarde aussi la consommation d'opiacés, alors l'héroïne seule, vous voyez qu'on est à 0,07, mais si on intègre héroïne, opioïdes antalgiques également, là on a un petit P qui diminue un peu plus, avec effectivement plus d'usagers actifs d'opioïdes dans le public qui n'a pas poursuivi. Le traitement préalable, je vous l'ai noté, j'ai surtout voyez, entouré la colonne de la population d'analyse parce que c'était pour bien voir l'information. On parle de personnes qui sont toutes déjà sous substitution, donc pas de public qui commence sa prise en charge avec le bufidal. Il n'y avait que 3 personnes qui n'étaient pas sous buprénorphine sur l'ensemble, avec une dose quotidienne qui était de 14 mg par jour, des prises qui étaient un tout petit peu au-dessus de 1, et des voies d'administration très majoritairement orales, avec 5 personnes qui sniffaient et 5 personnes qui injectaient, et donc parfois des pratiques mixtes entre le sniff, la prise sublinguale haute. Sur cette analyse-là, c'est cette fois pour vous montrer les schémas d'injection et les dosages, en distinguant toujours ces 2 populations, ceux qui ont poursuivi, ceux qui ont arrêté. Vous voyez, j'ai souligné les petits P pour vous dire que là, on a vraiment tout de suite, évidemment, voilà, vu l'intérêt de regarder tout cela en détail. Et alors, pour bien regarder un petit peu, parce que ça fait beaucoup de lignes, vous avez d'abord ici le schéma d'injection qui était retenu à l'initiation, c'est-à-dire celui, si on demandait au duo, on va dire, clinicien et usager, qu'est-ce qu'ils envisageaient, c'était ce qui était envisagé au départ. Et dès le départ, on voit une différence entre les 2 groupes, avec les personnes qui ont arrêté, qui avaient plus tendance à vouloir être d'abord sur l'hebdomadaire, soit que ça, soit tout d'abord avant de commencer le mensuel, et plus de personnes qui étaient sur, en tout cas, une projection dans le mensuel au début du traitement. Ensuite, il y a la réalité de ce qui a été la première injection, finalement choisie, et là, on est donc quand même sur de l'hebdo en majorité. Sur la population totale, on est sur 2 tiers en hebdomadaire et un tiers qui a eu la mensuelle directement, un petit peu plus du côté des personnes qui ont poursuivi. Pendant la période de titration, donc les personnes ont pu avoir des doses mensuelles et des doses hebdomadaires, mais là on voit bien que ceux qui étaient sous mensuel au moment de la titration, c'était 100%, ce qui n'empêchait pas d'avoir des doses par exemple complémentaires à 8 mg, donc ça rajoute des doses hebdomadaires en plus, d'où le fait que malgré le 100% ici, vous avez aussi des personnes qui ont de l'hebdomadaire. Et là on voit effectivement significativement le fait qu'on soit sous mensuel à cette étape de titration favorise a priori la rétention sous traitement. Le schéma d'injection à la fin de la période de titration, on retrouve la même question. Et si on regarde les dosages administrés, donc là vous avez tous les dosages et forcément il y a un petit peu une limite ici, j'aurais presque pu mettre un trait puisque en dessous on est sur le mensuel et au-dessus vous êtes sur l'hebdomadaire. Donc il y a le biais de ce que représente le dosage qu'il faut garder en tête et à l'esprit. Mais vous voyez que si on regarde même sur les mensuels, ici sur le 160 on a quand même 15%, plus de 50% qui sont à 128 mg. Quand on est tout juste à 20% pour la population qui a arrêté le traitement. Et donc ça questionne vraiment sur le fait que la poursuite du traitement soit associée au fait de bien accéder à l'expérience du mensuel et d'avoir accès à des dosages suffisants. Ici, c'est pour vous montrer une donnée plus qualitative par rapport à l'échelle des changements perçus qui permet d'avoir tous les items que vous voyez ici sur cet axe, qui va de aucun changement en tout premier à évidemment plus de changements et positifs, puisque le tout dernier, c'est je vais beaucoup mieux, avec une amélioration considérable qui a fait toute la différence. Donc là, c'est vraiment un franc changement. Vous avez en violet les non traités à 6 mois, donc les gens qui ont arrêté, en jaune ceux qui sont toujours traités à 6 mois, et en rose la population totale. Et donc, bien sûr, on voit bien qu'aucun changement, voire c'est du négatif. C'est là qu'on a une population importante de personnes qui ont arrêté. Mais vous pouvez tout de même remarquer que même dans ceux qui ont arrêté, on en retrouve un certain nombre dans des vécus assez positifs de changement, voire même d'amélioration nette. Bien sûr, dans les traités à 6 mois, on voit vraiment que, bien sûr, qu'il y a un impact, une positivité de changement qui est bien présente. Et puis de voir qu'effectivement, il y a, on s'en doute pour le coup, une différence significative. Mais c'est intéressant tout de même cette expérience positive qui n'est pas toujours la cause stricte de l'arrêt du traitement, comme on l'a vu, puisqu'il peut y avoir une manque d'efficacité, des douleurs, des choses qui ne conviennent pas, mais ça ne veut pas dire que l'expérience est nécessairement négative. Pour ce qui est des comportements à risque, on avait des informations sur les overdoses. Il y en avait 2,7% dans la population avant traitement, 4,2% après, sans qu'on puisse là avoir une significativité de différence. On verra sur la population totale. Les hospitalisations au passage aux urgences, vous voyez que là, avant le traitement, on a 16,4% d'hospitalisations au passage aux urgences qui sont retrouvées dans les dossiers, contre 1,4% depuis la mise sous buvidal. Et si on regarde les consommations, vous avez le petit histogramme à côté avec le fait qu'il n'y ait pas de changement dans la consommation, pas de changement rapporté par le patient, ou une diminution ou une augmentation, donc la diminution en violet, l'augmentation en rouge. Vous voyez les opioïdes en premier, avec pour le coup, lorsqu'il y a un changement qui est franchement du côté de la diminution. Pour d'autres drogues hors cannabis, donc drogues illicites, donc notamment la cocaïne, crack en première ligne. Là aussi, on a plutôt un peu plus dans la diminution quand même que dans l'augmentation. Pour ce qui est de l'alcool et des benzodiazépines prescrits, là on voit qu'il y en a quand même un certain nombre qui ne décrivent pas de changement, mais tout de même, certains qui diminuent et un petit peu d'augmentation. Les médicaments non opioïdes mésusés, là pour le coup c'est un tout petit effectif. Et sur le mésusage du traitement de substitution, là, on voit bien qu'on a du coup, pour le coup, une diminution avec un arrêt souvent des prescriptions en plus du buvidal, donc qui explique. Mais ça n'empêche pas de se fournir à la rue, donc c'est quand même les usagers qui déclarent arrêter ces comportements de consommation de mésusés de traitement de substitution. Alors, quelques points de discussion. Donc, OPALE 2, on a dit le taux de rétention est à 72,6%. Sur OPALE 1, avec les 34 patients dans notre centre, on était à 70,6%, mais c'était une analyse photographique vraiment après 6 mois d'inclusion, donc on n'avait pas le recul de 6 mois après la première injection pour tous les usagers. Je vous ai mis quelques exemples d'études. Il y a eu des exemples même précédemment qui ont été donnés par les autres intervenants. Voilà, ça peut vraiment, on voit une certaine variation. Une étude de ATHS où c'est 62 à 64% à 3 mois. Une étude de McDonald's où on était à plus de 90% à 1 an. L'étude d'English où là, on avait buvidal et sublocaine où on était à 63%. Je vais souligner au passage qu'il y en a quand même un peu plus de 10% qui ont fait du choix de changement entre les différentes formes. CLEA 2023 avec 40 patients qui avaient un taux de rétention à 52,5%. Donc on est quand même globalement largement au-dessus plutôt des 50%, mais il y a encore une grande variabilité. Vous voyez, on est sur des effectifs qui vont de quelques dizaines de patients à quelques centaines. Je vous ai indiqué pour CLEA qui travaillait sur les causes de l'arrêt. C'était le premier élément de l'étude. Et vous voyez ici, l'équipe citait en premier lieu le fait de se sentir forcé à intégrer le programme. Donc ça rejoint un peu l'introduction du président MAREMMANI sur l'attention au parallèle avec la psychiatrie et le fait de chercher à pousser aussi au traitement pour pousser vers l'observance du traitement et qu'on n'est pas dans les mêmes problématiques ici. Et donc, je ne sais pas quelles étaient exactement leurs modalités pour inclure, mais en tout cas, c'était vraiment le discours qui était le plus fréquent. Donc, parfois, attention à notre enthousiasme de prescripteur ou au contexte dans lequel on se trouve pour ce qui va être du vécu du patient. Et ensuite, les effets secondaires, ensuite, le manque d'efficacité. Donc là, on retrouve des choses qu'on trouvait également, nous, dans d'autres études, beaucoup. Les souhaits d'arrêter ou de consommer des opiacés. C'est vraiment aussi parfois un retour d'usager que de dire je vois l'efficacité, mais je ne suis pas encore prêt à arrêter mes consommations. Donc, j'interromps le traitement pour pouvoir aussi reprendre et peut-être me laisser plus de temps. Et le fait aussi de s'être senti guéri, puisque l'arrêt de la prise quotidienne provoque une distanciation avec le vécu de l'addiction et de la dépendance, qu'on retrouve également auprès des usagers, et qu'on avait dans OPALE 1, et puis on en reparlera parce qu'il y a aussi cet élément dans OPALE 2, que ce n'est pas forcément tout de suite intégré ici, sur cette mise à distance de la dépendance, et qui fait que certains interrompent, mais au sens d'interrompre le suivi, sans forcément redemander de reprendre l'autre traitement de substitution, en voulant expérimenter ce qui se passe s'ils laissent l'effet de cette injection qu'ils ont eu se poursuivre sans reprendre d'autres traitements jusqu'à ce qu'elle soit éliminée de l'organisme, pour rejoindre aussi le sujet sur l'arrêt du traitement de substitution. Alors, quelques remarques sur les limites. Donc, on est bien sur une analyse intermédiaire, donc nous, on n'est pas à notre effectif encore complet. Donc, on espère que ça permettra d'affiner, de donner encore plus de données, puisque je ne vous ai pas évidemment indiqué tout ce qu'on a essayé de regarder. Il est important, comme on le disait en introduction, de se rappeler que le 160 mg n'est arrivé qu'au cours de la période considérée. Donc, on a intégré des personnes qui n'avaient pas pu bénéficier d'une prescription de 160 mg dès le début de leur prise en charge. Or, on le voit quand même dans l'étude, donc on voit bien qu'il est utilisé, et ça peut d'autant plus poser de questions à partir du moment où on observe que cet enjeu autour du mensuel et des dosages suffisamment importants peut être un enjeu de satisfaction pour maintenir les personnes sous traitement. Donc c'est un biais évidemment pour nous qui est non négligeable. Et puis l'autre biais également, c'est de savoir le contexte français de la limitation quand même actuelle du financement du Buvidal, qui on peut l'imaginer, créer des biais de sélection des patients. Ce que je veux dire, c'est qu'on a un système où on nous a dit on peut le prescrire dans les XAPA, les centres d'addictologie, et on peut le prescrire à l'hôpital. Pour autant, et donc le prescrire et l'administrer sur place. Donc on ne peut pas le prescrire à une pharmacie. Donc on doit nous-mêmes le fournir aux patients. À l'hôpital, on a un système de tarification à l'acte, donc ça permet, pourquoi pas, de trouver des formules où on va le financer à travers cette tarification des actes. Et pour les XAPA, qui sont des structures médico-sociales, vous le savez, pour un certain nombre, on a un budget qui est alloué au traitement par l'ARS, et l'arrivée du Buvidal n'a absolument pas conduit à une majoration des traitements, alors qu'au niveau du centre, son coût est supérieur au coût de la dispensation d'un traitement sur place ou d'une prescription en pharmacie, bien sûr. Donc on est dans un système qui freine le fait de pouvoir proposer, puisqu'on a un certain nombre de centres qui sont limités dans le nombre de places et dans l'estimation du budget qu'ils ont sur ce qu'ils vont pouvoir fournir comme traitement à des usagers. Et donc l'inquiétude, c'est que cette situation fasse qu'on se censure et qu'on ne va peut-être le proposer qu'à des personnes, enfin déjà pas à tout le monde, en se disant si je dis à tout le monde, qu'est-ce que je fais? Est-ce que c'est les premiers qui me demandent à qui je le donne? Est-ce que je cible un public plus spécifique? Mais du coup, sur quels critères je le cible, étant donné que pour l'instant, au niveau de la littérature internationale, on a tout juste des premières analyses sur ce qui fait qu'un patient reste sous traitement, et pas du tout des critères sur qui il faut prioriser. Donc voilà, c'est important d'avoir ça en tête sur notre contexte en France, et de savoir qu'il y a sûrement des biais de sélection implicites de patients dont on espère que la situation pourrait à terme se débloquer. En tout cas, on l'attend tous. Et c'est un petit message pour nos instances et nos institutions françaises qui continuent de nous bloquer dans ce système de développement. Et pour conclure, voilà un petit remerciement évidemment, un gros remerciement à toutes les équipes qui ont participé, qui sont indiquées ici, avec en particulier le comité scientifique. Et puis donc on vous donne rendez-vous pour l'analyse sur la cohorte complète à 200 patients.
Nous avons là, après ce panorama des 4 présentations, nous avons 15 minutes de discussion et on va donner donc la parole à la salle. Théoriquement, John Marsden est avec nous aussi connecté, enfin je l'espère. Est-ce que vous avez la connexion avec John pour qu'il puisse participer à la séance questions-réponses? Sinon, on va commencer avec les auditeurs présents, bien entendu. Alors, y a-t-il des questions dans la salle? Ah, John, hi.
Hi, good afternoon.
Nice to meet you.
Pleasure, good afternoon. Sorry I can't be with you in person.
It's okay, you're welcome. Donc, alors, Donc, on a vu effectivement à quel point, et pour l'ensemble des orateurs, à quel point finalement, donc, le premier temps est très important, on le sait notamment avec la buprénorphine qui permet une titration plus rapide que la méthadone, que c'est un moment essentiel effectivement pour permettre aux patients de s'inscrire dans le traitement. Alice, tu l'as montré, et on le voit dans notre expérience aussi de prescription de ce médicament, à quel point finalement, si au départ, nos représentations de soignants, on voulait d'abord commencer par des choses plutôt progressives, avec des courtes durées, finalement, on voit à quel point le fait de permettre d'apporter un confort rapide, qui permette aux patients de se stabiliser, parce qu'on voit bien que si, avec une semaine, il n'est pas stabilisé, tout de suite, l'anxiété anticipatoire, le fait que ça ne marche pas, et que ça réactive toutes ces vieilles habitudes, on voit à quel point c'est important. Et in fine, à quel point il est important d'apporter quelque chose qui permet de les inscrire rapidement dans une stabilité. Et on voit la stabilité, c'est non seulement la durée dans le temps, mais le bon dosage. Alors du coup, c'est une question à tous les orateurs, puisque l'objectif, c'est de croiser les regards de votre expérience internationale. John, you are of course welcome in the discussion.
Je veux bien commencer si ça vous ennuie pas. Enfin, moi, je te rejoins tout à fait. On a fait aussi du coup un poster justement pour regarder et pour, en tant que prescripteur, se rassurer de regarder aussi nous finalement entre le dosage qui est censé être indiqué par les équivalences entre le sublingual et le dépôt. Et de regarder ce que les prescripteurs avaient fait chez nous avec tous les mois de recul qu'on pouvait avoir. Et ce qu'on voit finalement, c'est qu'on a eu tendance à sous-prescrire au début. Alors qu'en fait, très vite, en suivant, par contre, il y avait heureusement une politique de suivre la demande du patient, de lui mettre des dosages complémentaires s'il le demandait, que ce soit oral ou en complément. Et donc, on voit que finalement, on monte au-dessus un peu de la dose recommandée pendant 3-4 mois et qu'en fait, au final, la courbe revient sur le tableau d'équivalence une fois qu'on a passé ces premiers mois. Ce qui nous fait penser que, en tant que prescripteur, on a tendance à se mettre un petit peu en dessous par inquiétude. Et j'espère qu'au fil du temps et de l'apprentissage et avec les messages qu'on peut se donner et apprendre qu'il n'y a pas d'inquiétude et qu'il faut y aller, surtout pour des personnes déjà sous traitement de substitution, déjà sous buprénorphine, où vraiment il faut qu'on sorte de nos inquiétudes d'avoir ce traitement d'action prolongée injecté. Et que probablement au démarrage, le temps que la dose se stabilise quand même sur 3-4 mois, eh bien, il peut y avoir un intérêt à être un peu au-dessus pour justement renforcer le confort de la personne et qu'ensuite, avec la régulation, il peut y avoir une petite réadaptation qui arrive après, mais qui a permis l'adhésion et la satisfaction, surtout de l'usager.
Alors, j'ai parlé pour John aussi, this is really interesting because what you are showing, it's a kind of schema with the sublocade protocol, with the high dosage, with the 300 milligrams of the first time, and then you switch to the 100 milligrams. And interestingly, in your study, John, there are some people staying with the 300 milligrams or the protocols. And I would like your opinion, Adrian, because you have both experience with the two medications, Buvidal and sublocade. So,
great, thanks, Maurice. So, I think there's two things. Clearly, it's very important that prescribers and other clinic staff have a good understanding of dose conversion, of the appropriate induction regimen, that there's a difference in patients' response. Some patients, will need a higher dose, some patients will need a lower dose. But if you get that wrong, it's a recipe for poor uptake of a medication. A really good example there was a slide this morning Ivan Montoya showed. So LAM, levoacetyl alpha methadol. When that was first researched, there were a number of centres where the clinic staff were less enthusiastic about it, and in randomised studies, and it was sort of presented to them, if you get this option, it's not so good. And of course, the patients didn't do so well. So with either formulation, weekly, monthly, Buvidal sublocade, as well as understanding dose conversion, as well as understanding how to give the patient the appropriate dose, as well as listening to the patient to make sure that, if the patient's saying, I feel I'm withdrawal, thinking about that, thinking, are they really in withdrawal? Yes, they're in withdrawal, let's give them some more, or educating them if they're not really in withdrawal. All of those things are really important to try to have effective uptake.
Yeah, that's why it's very important assess the patient rapidly and to make sure that everything is okay so he can stay in treatment most comfortable as possible. So, John, in your experience with the study that you conducted, you mentioned the differences in the different patients with the different dosages. Can you describe the different situation, different characteristics of these patients? Oh, we don't listen to you.
Forgive me. It's a really interesting question, and actually we've got a layer of secondary analyses correlating characteristics of patients and treatments on those heat maps I showed. As I think I mentioned, we had, generally speaking, in the way that we had our own, if you will, study label, the regimen of following essentially the same as the manufacturer's recommended label, except we encouraged patients to come in a little earlier if they wish to for their second loading dose. So this is just really anecdotal. I can recall a participant that in the past had split their doses of buprenorphine. It's possible, we've never tested, but it's possible they metabolize it quickly. Certainly they were concerned to experience, that they might experience breakthrough withdrawal symptoms in the injection window. And that particular participant did request rescue oral medication. There wasn't a particularly convincing somatic justification for it. So I think we are channeling to a degree some aspects of patient sort of lived experience. You know, we did a study in which a fair number of our patients were familiar to us. They'd cycled through episodes of treatment before. So they're familiar with our standard of care. They're familiar with dose adjustments. In England, we've got a long-standing history of being very coy about trying to help people taper with what used to be called methadone reduction programs. They were rather unfortunately implemented clinics in which there was nervousness about maintaining therapeutic doses that was fairly static, and there was a sort of inherent wish for patients once stabilized to be tapering, however slowly, and that generally resulted in a sort of rebound from a low dose back up to 50, 60 mgs of methadone, etc. So aside from that one example of a patient characteristic in which we maintained 300 milligrams, I would say generally that probably in our study would be too few a set of patients for us to do any characteristics analysis. But generally people were quite happy. There was some examples of patients saying that they were happy to be on 100 milligrams because it was easier to receive in terms of the loading doses. It is more painful acutely. The pain that patients experience was very rapid and resolving. We used cold compress, etc. With a little motivation and sort of reflection that, oh, it's good to be on the 100 now. But generally, I think if you look at the pharmacokinetic and dynamic literature that supports that particular injection, there's good evidence for the 100 milligram maintenance phase, really, in terms of, stability and also, clinical and therapeutic response.
Thank you. We're learning a lot. We're doing an experience, patient, and healthcare professional as well.
One question for all the speakers. What about the use of implant or dépôt buprénorphine for the case of overdoses in emergency room?
So we don't have any experience with implants, so I'm sorry I can't add to that. I guess, theoretically, the practicalities of management would not be different. You would still use the same, first-line treatment.
Yeah, yes, because generally, if a patient don't want to enter the treatment after an overdose, it's a problem. But during an overdose, there is a necessity, a moment in which the doctor can inject buprénorphine depot and so protect for a little bit the patient when is released from the hospital. A sort of harm reduction that I think in the future is important, especially in the United States and in England, because the problem of overdose is increasing worldwide, unfortunately.
Une question. Sandra Comer.
Thank you.
Just a remark from me. If Adrian has spoken, hello, my friend, nice to see you. I think that question is so on target. If we were to wriggle our noses and transplant ourselves into Chicago, Milwaukee, Boston, New York City in the US, is one of the completely preoccupying questions at the moment, which is trying to help people that survive opioid poisoning and are attended by emergency personnel, and to see if people would be interested in having a rapid induction into maintenance medication in the way that you suggest. I don't believe they're using the subdermal solution there, so I think it would be weekly or monthly. But it certainly preoccupies us. I think I may have mentioned in my recorded talk that we only have isolated and rapidly resolving outbreaks of fentanyl analogs at the moment. But there is some literature that would give us some encouragement that depot buprenorphine will be a clinically valuable response to people who suffer these incredibly devastating and potent synthetic addictions. So I think that looks like a valid and useful option. For example, in the prison system in England, if we had someone, for example, who is about to be discharged from a prison in London, they normally do that on a Friday afternoon, just after the housing department is closed, somewhat ironically. But say you've got someone with a very high risk history who's not on a full or a partial agonist. I do wonder about the idea of giving them 3 50-milligram naltrexone tablets. If they take them, they would have the chance of surviving the weekend. We've done studies showing that there's an awful risk profile of inmates leaving with a strong footprint of heroin addiction who wander into a local bar, homeless after release, consume alcohol, then buy heroin and die. So that's another example of how one might, use prophylactically an antagonist briefly for that high risk period. But I don't believe it's ever done, but I certainly can't see any reason why you wouldn't want to do it, unless the person has got some known hepatic problems.
Thank you, John. A last question from Sandra.
Thank you. This is Sandy Comer from Columbia University. My question is for John, actually. So thank you, John, for your presentation. I really liked seeing the heat maps that you made. But I'm wondering, in the sublingual buprenorphine versus the Sublocade groups, did you ask the ones who used why they used, or if they felt high? I mean, were the ones who received Sublocade just kind of experimenting and didn't really get high, or anything like that? I just was wondering.
Oh, thank you, Sandy. It's so nice to see you in the audience. I wish I could be with you. I hesitated. We were very fortunate to receive a small grant to hire an audiovisual company to do some short interviews with participants that had been enrolled in the Sublocade arm. And so we've got sort of a little library of 12 recorded accounts in which I asked patients some general questions about their motivations and for taking part, and also, you know, the kind of 72 hours after dosing, in particular, to your point, and beyond. And certainly we had a few folk saying in that video interview format, well, I was told that I could, of course, use heroin and, you know, nothing would happen adversely, but I'd be, you know, wasting my money perhaps. So that's a quote from a particular exchange with a patient. And so there was a little bit of testing whether there was a blockade effect. And in a way that one might have a virtuous cycle of effect with Vivitrol, for example, you know, some of our patients were definitely saying, well, it didn't work. What did I expect? And then they would reflect on their motivations for taking part. And there was a little sort of reflection that if they then were in contact with people where there was the offer to buy stimulants. So most of our patients are offered heroin and cocaine at the same time, it's certainly in South London, where I'm based. That the knowledge that they were covered to at least the next dosing, and possibly, as we know from the PKPD data, far beyond it, that would help them in their response to the urges to use. The other times we'd have patients that said, this is completely crazy, isn't it? I have continued on occasions to smoke heroin, usually when I've been smoking cocaine, and I've got nothing from it, but I guess it's the habit, doctor, what do you think? And so those little sporadic dots of red that I showed are probably the kind of not attenuating legacy of strongly conditioned behavior that it seems to me calls for our clinical attention to sort of work with, you know, a CBT or some other intervention. So, but we also found in the big sort of green bar at the top of those heat maps for the Sublocade arm, that craving was turned off like a light switch for a good number of patients. They would be a bit exasperated with our form, and they would say, look, I don't experience any distressing craving at all. Why are you asking me? You know, and that was really exciting, and we're obviously interested in trying to, you know, explore that a bit further. But there was definitely a turning off that meant that there really wasn't a sort of cognitive undertow of urges to use at all for a good number of people.
Thank you, John. The time is over, but we have a very last and short question from Jean-Pierre. So we ask a very short answer.
Oui, je dois être exemplaire comme organisateur, et donc un bref commentaire et une question brève aussi. L'expérience des premiers patients traités par le long-acting avec Buvidal nous a fait découvrir quelque chose qui passait inaperçu. Je veux dire que la prise sublinguale de buprénorphine est rapportée par les patients, est d'abord très fastidieuse et souvent mal faite, amène à une mauvaise biodisponibilité. Mais surtout, ils décrivent de réveil le matin en manque, et ensuite ils éprouvent un moment de high, et donc au cours de la journée il y a des épisodes de high, de down, et c'est une dimension qui apparaît comme extrêmement conditionnante quand on sait que c'est une pathologie très conditionnée. Et donc, en bref, cette redécouverte de ce qui est une évidence, que c'est une pathologie très liée au conditionnement, en ce sens, je reprends ce que j'ai dit aux autorités sanitaires pour les convaincre de financer le traitement en France. J'aurais dit c'est de la buprénorphine, mais ce n'est plus le même traitement, parce que le confort que rapporte le patient est lié au fait qu'il n'y a plus ces hauts et ces bas. Et bon, peut-être que cet aspect sur le conditionnement peut amener un bref commentaire de nos invités, que je veux absolument remercier pour le caractère tout à fait remarquable de leur présentation et très utile. Nous sommes probablement à une nouvelle révolution thérapeutique. Merci beaucoup et pardonnez-moi d'avoir pas donné le bon exemple.
So the time is over. We close the session. Thank you very much to the speakers and thank you very much for the participants to attend this session.